Good afternoon, ladies and gentlemen. Welcome to our SingLIVE online program. We have a very interesting session today on TAVI with live transmission from Lausanne, Switzerland, focusing on transcarotid arterial or transcervical access for TAVI. So even though TAVI devices have improved such that the majority of patients can undergo transfemoral TAVI, still a minority of patients may have hostile anatomy that are unsuitable for transfemoral approach. Join us in this session as we learn how to select, screen, and plan for transcarotid arterial access for TAVI, the tips and tricks to perform this procedure with excellent clinical outcome, and how to monitor patients post-procedure. Co-chairing with me today is Dr. Eric Eckhout from Switzerland. He's currently with the performing team. And before I pass the time over to him, we do have a distinguished panelist of experts, key opinion leaders. They include Dr. Rosli Mohammed from Malaysia, Dr. Wasim Budari from Thailand, Dr. Pravin Chandra will be joining us shortly from India, Dr. Victor Chow, our cardiac surgeon from Singapore, Dr. Chuchli from Switzerland, and last but certainly not least, Dr. Goubet, a very prominent pioneer in TAVI. Glad you can join us all. This chat is moderated by Dr. John Yap. If there is any questions, you can just type it into the chat function, and Dr. Yap would help us deliver the questions and we can address. So without further ado, I would now pass the time over to my co-chair, Dr. Eric Eckhout, to introduce his team and case today. Eric?
Yes. Thank you so much, Kaiwon, for the nice introduction. Indeed, we're very happy and very honored to broadcast again the second year in a row from CHUV here in Lausanne. This time an alternative approach after the hypnosis case last year, transfemoral, this time a transcervical. And you will see the real teamwork, which is highlighted by a number of people surrounding me here in the lab. And I have the privilege to present them all. I will present them by their first name because it will take me some time. We have a team of anesthesiologists, Lorenzo and Marie, who will be the anesthesiologist. We will be helped by Emily, the nurse. Our cardiac surgery team standing behind me, Matthias and Ziad, the surgeons. We have the scrap nurses, Josie, Agnes, and the assistant Lourdes. And now, of course, the cardiologist, humbly behind, Vladimir and Olivier, the cardiologist, Pascal, the nurse who will prepare the valve, Marie, who will be in charge of the pacing aspect of the TAVI procedure, and Lisanne a little bit behind the console in the back, controlling everything. And then behind the screen, two people, Nadia and Marion, who helped us to prepare this case. Without any further ado, I will now ask Olivier to present basically the objectives of this session and of this live case transmission. Olivier, the word is yours.
Thank you very much, Eric. We are very pleased to demonstrate today. The first objective is to demonstrate how to perform a transcervical TAVI. Actually, we are grouping the transcarotid, the transbrachiocephalic, and the transsubclavian in one word, which is transcervical. And Matthias Kirsch will go through these details afterwards. He's the surgeon. So this is the first objective, and the main objective is to demonstrate how to perform a TAVI through a transcervical route. The second objective, I would say the specific objective, is also to show you how to create an environment which is suitable for this route. Indeed, everything has been set for the transfemoral route, but now we have to adapt the material, the TAVI wire, and all the specificity of the transcervical. So these are the main objectives, is to demonstrate how to perform a transcervical TAVI.
Thank you very much, Olivier. So we will now head to Marion, who will present the clinical case to you. We have to turn to Marion.
Dear colleagues, it's my pleasure to present you today's live case from Lausanne. I'm Dr. Marion Dupré from the 3 operators.
Oh, sorry, we can't really hear Marion. Can the mic be positioned a little bit better?
Microphone is coming.
Yeah, 1 second.
Sorry for that.
Do you hear Marion?
Yes,
Can you
very
hear
clear
me?
now. Yes.
Okay.
Thank
Dear
you.
colleagues, it's my pleasure to present you today's live case from Lausanne. I'm Dr. Marion Dupré, and the 3 operators will be Professor Muller, Professor Kirsch, and Dr. Rumbimbura. Next slide, please. Here you can see our conflicts of interest. Next slide. So, our patient is a 84-year-old gentleman, and he's known for hypertension, hyperlipidemia, and permanent atrial fibrillation. He underwent atrioventricular node ablation and is equipped with permanent pacemaker. In November 2020, he was hospitalized for acute heart failure. His echocardiogram showed at that time a severe aortic stenosis characterized by paradoxical low-flow low gradient. His ECG showed atrial fibrillation with ventricular stimulation at 70 beats per minute. He has moderate anemia and a renal failure stage 3. His current medication consists of rivaroxaban, metoprolol, and torazimide. He stopped his anticoagulation 3 days ago. Next slide. His echocardiogram showed normal biventricular function and an aortic valve area of 0.6 square centimeters and a mean gradient of 30 millimeters of mercury. His coronary angiogram didn't demonstrate any significant coronary lesion. Next slide. His CT scan confirmed a calcified aortic valve with a calcic score of 2017 units. The aortic valve area was measured at 584 square millimeters. Next slide. Regarding peripheral vascular access, the CT scan revealed severe arterial peripheral disease. As you can see, there is several plans of dissection with mural thrombus in abdominal aorta, but also in right illeofemoral arteries. In the right side, the lumen is too small to the transfemoral approach. In the left side, the common iliac artery presents a strong angulation, and there is a small dissection at the femoral puncture point. This condition is incompatible with classic transfemoral strategy. Next slide. On the other hand, supra-aortic vessels are free of any significant disease. The diameters are large, and there is no significant angulation. Overall, considering the age of the patient and the contraindication for transfemoral approach, we opted for TAVI using the transcervical approach. And finally, considering the 3-man-show analysis, the valve chosen was a Edwards Sapien 3 29 millimeters. And now I will give the word to Professor Eckhout.
Okay,
Oh,
so
Professor
thank you
Muller.
very much, Marion. Now we are ready to go on with this procedure. I think the main objective now is that Matthias Kirsch can discuss the access route, which is the main difference between the transfemoral and transcervical. So, Matthias, please.
Yes, well, good afternoon, everybody, and thank you, Olivier. Can we zoom maybe on the surgical side, please, with the camera? Yes. So just for the sake of orientation, here you have the jaw of the patient, here. Here you have the shoulder, and here you have the sternum. Okay, so we use here a pure cervical approach, meaning that we don't open the sternum or the manubrium. In that case, we use the direct transaortic approach. So our incision goes here from the suprasternal notch along the anterior border of the sternocleido anterior muscle. The length, bistouri, the length is roughly 7 to 8 centimeters, just a straight line along the border of this muscle. Then it's like for a standard cervical approach. Ça, il faut enlever le... Here,
So,
I don't know if you can see it good enough. It's the anterior border of the sternocleidomastoidean muscle.
So how
I
is
can see
the
it very well.
transmission and the imaging? See it very well.
It is
Yeah.
very clear.
Basically, Matthias
Very
is
clear.
wearing a camera on his head. You know, it's a GoPro type. Any comments on maybe while Matthias is doing that, we can ask the panelists how they proceed in patients with inaccessible femoral roots. We have not opted for transcaval, but maybe you can ask while Matthias is doing this, you can ask the panelists in that will enable Matthias to work quietly on his preparation of the artery, and maybe you can do a round table on the approaches.
What would your country's approach be if you can't do TF?
Well, I can't speak on behalf of my country, but my center, I guess we usually look at the left subclavian and the direct aortic, and occasionally right subclavian all together at the same time. If the left subclavian is large, it's not added too much. It has to be like well large enough, then left subclavian. But I think more recently we tend to go for direct aortic because our left subclavian are relatively small, diseased, and angulated.
Rossley, is that the same situation in Malaysia?
Yeah, it is. So in cases like this, if it's really not possible for transfemoral, and as what was said, the sizes, we tend to go to direct aortic route if the subclavian are small.
So the situation is similar in Singapore. Okay. So we look at the subclavian, both the right and left subclavian, and whether it's possible. If not, direct aortic and transapical are alternative access sites. Dr. Grube, I'm sure there are lots of other sites that are used in Germany. So what would be the second concept?
I have to say, first of all, thank you very much for having me, and I'm interested in looking at this because we have reports on transcarotid approaches. Actually, many years ago, I have done together with a cardiovascular surgeon and vascular surgeon a transcarotid approach when we really didn't have any access. So not that I wanted to criticize or question anything. I would actually say that I don't think you can call this a contraindication to transfemoral approach, because yes, there is a bend, but if you put a relatively stiff wire in it, I'm sure, at least looking at it from here without going into too many details, I think you could manage it to get the transfemoral. The other thing is, since we do not have any experience anymore with transcarotid approach, we would also go to the subclavian, which, at least looking at the picture, would be an option to get to the heart.
So I think for majority,
your point is well taken.
On voit quelque chose là. Mets la lumière. Est-ce qu'on peut faire des commentaires là?
Eric.
Okay. Yes. Maybe while we you can have a look at the valve preparation because, of course, Olivier, do you want to comment on the?
Yeah, first I think Matthias wants to comment.
Okay, Matthias wants to first show you something. Yeah. Okay, we'll come back to you, Eberhard, later.
I just want to show you the approach here.
Okay.
Maybe I hope that through the GoPro you can see at the. I'm trying to get closer to the incision. Here you have the primitive carotid artery. You see here the bifurcation of the brachiocephalic trunk. You can see here the beginning of the right subclavian artery. So we call it a right cervical approach because we do not choose a priori the vessel we're going to cannulate. So once it's open, we choose the vessel which is the most easy to access and to cannulate. Okay. So most of the time it's the right primitive carotid artery, sometimes it's the brachiocephalic trunk, and quite rarely it's the right subclavian artery.
Okay. Olivier, do you want to comment briefly? Can you put the camera now on the valve preparation? We'll shift cameras to the valve preparation, and maybe Olivier, you can comment briefly the difference with the classical sheet.
Okay.
Loader.
Yeah, I don't know where. Yes, fantastic. So it's a little bit different. This is the introducer sheet. Indeed, it's a small one compared to the femoral one. It's 21 centimeter, the sheet, and the introducer is 33 centimeter. Very simple. So today we have a 29 Edwards Sapien 3, so it's going to be a 21 French, the size of the sheet. And here we have the delivery sheet system, and indeed it's much more simple, I would say, and shorter. This is 55 length, and you have steering actually catheters, so in one direction compared to, I don't know if you can appreciate the way I can bend the guiding catheter and debend whether we need it or not. We'll see directly during the procedure. So this is mainly the main material that we need compared to the transfemoral, and Pascal will start to prepare the valve now.
Okay, so
same thing.
Excellent, thank you very much, Olivier. So maybe we can use split screens, one screen on the valve preparation and the other split screen for the access and the preparation by Matthias and his team. Matthias and team, are you almost ready to puncture the
Yes, well, we have to perform the carotid occlusion test, which we perform systematically. I think Lorenzo is going to talk a bit about that. But if you just look at the screen, heparin has been given just now. So 1 minute after the administration of heparin, we occlude the right primitive carotid artery to see if the patient is going to support this procedure. Occlusion carotidienne. And maybe you can see here now the NIRS. Lorenzo, tu fais le...
Yeah.
On peut pas voir là.
So you're occluding the carotid artery. What are you monitoring at the moment?
It's the NIRS, Lorenzo.
Yeah, it's going to explain for the presentation for...
Good afternoon, everybody. I'm Lorenzo Resner, senior physician in anesthesiology, joined by Mary and Emily here for anesthesia. I'm here just to explain you how we conduct anesthesia and how we monitor this patient for a transcervical TAVI approach. Compared to the transfemoral approach, in which the patient is under a sedation with a direct neurological control, in this situation with transcervical approach, the situation is totally different because the patient has to be under general anesthesia. Local regional anesthesia will be highly uncomfortable and likely dangerous for the patient. Going quickly for the equipment, sorry, next slide. For the equipment, the patient is under general anesthesia. He has 2 IV lines. The first IV line is for the narcosis, so there is continuous infusion of propofol and remifentanil. The second one is for narcotic effect. For the second IV line, we have norepinephrine in continuous perfusion to counteract the vasodilatator properties of the narcotic agent. We have also an arterial line on the left artery, left radial artery, that we are putting before of starting general anesthesia to control tightly the blood pressure during all the procedure. We have also the pads for the CPR and defibrillator that are on the patient. And the most important thing is that contrary to the transfemoral approach here, the only way to follow the neurological status is to follow the NIRS. So the NIRS is a tool that we can use to see the cerebral saturation indirectly. The normal range with an awake patient are between 55 and 75. So once we put to this patient that they were 60, and we can follow that value throughout all the procedure. We are doing a baseline test at the beginning. So the baseline was 60, and we did now the test of clamping of carotid artery on the right side, and at the saturation of more than 20% of the baseline or less than 50% in absolute value, it will be pathological, and it in that have to stop the procedure because of the big risk of ischemia, cerebral ischemia. This territory of cerebral territory are very prone to ischemia. So in that case, it was good the test. For last but not least, we can go further. Sorry. Next slide. Sorry, I was a little bit late. So just to show you about the value of the NIRS and this electrode that we apply to the scalp of the patient, the registration of the saturation, it will be deep 2 centimeters under the scalp. And on the left side, we are seeing the left and the right hemisphere. So this is our normal value. Also for this patient are staying normal. So next slide. Last but not least, we have to pay attention. Wait, this is good. Last but not least, we have to pay attention to other features that are primordial, that are very important. The first one is to be as ergonomic as possible in such a narrow place where to have to share the space with so many other colleagues. And also the most important thing is to communicate clearly and continuously with all the rest of the team. Next slide. So just to see that the monitor and all the anesthesia equipment will be minimalist. We have just a chariot in which there is the ventilator in the center. On the it's colored in orange. We have 4 infusion pump on the left side for the propofol, remifentanil, norepinephrine, and we have a monitor for the electrocardiogram, for the blood pressure, and for the depth of anesthesia. Yeah.
So,
thank you very much for handing over the microphone again. So I think Olivier and Matthias and Vladimir are ready to puncture now.
Yes.
Directly.
Just
so
before.
Yeah.
Yes, just before we puncture, you see here maybe we make a pull-string suit around the puncture site to control the bleeding one should use the sheath. And the second safety tip should be that you should always be able to clamp upstream and downstream of the puncture site. In this case, for example, we wouldn't go and puncture the brachiocephalic trunk because it's not controllable. So we are going to puncture the right primitive carotid artery. Introducing a guide wire.
Scopie.
There she is.
So maybe also if we can at the same time focus on the valve preparation here by Pascal. So maybe split screen, one split screen on the puncture. That's Olivier and Matthias.
Yep.
And one detail screen on the valve preparation. Pascal, you can go ahead. And so one of the physicians has to comment on position, and it can also be confirmed by the panelists. I think you all know how the valve should be crimped on the loader. Vladimir, do you want to go and check the valve position?
Yeah, sure.
So what is being done now? There has been a puncture introduction of a 6 French regular sheet. This is a multi-purpose in place, and you see that basically a soft wire is sitting on the valve. And the next step will be, of course, to cross the valve with the wire. We mostly use straight thermo wires, which is the routine practice over here. How is the valve position?
The position as well. Exactly.
Do the panelists confirm that the valve is at the right position?
A little bit far, can't see, but yeah.
You can't see? Can you focus on the valve? Can you zoom? Do you see the valve now?
See the skirt? Yeah, yes, it is correct position.
Everybody agrees that's it in the right position?
Yes,
I don't hear you very well from... You agree? Okay, perfect.
Yeah.
Okay, so Pascal will continue the crimping, and in the meantime, Olivier, and if you can focus, maybe zoom out on. I think it would be nice to have a picture of Matthias and Olivier now trying to cross the valve. If you can come back with the over here. Can we have a zoom image video of Olivier and Matthias trying to cross the valve?
Did they cross it very successfully?
Did you cross already? Yeah, you crossed, yeah. Okay. So, I think you need to zoom out.
So I don't know whether I can just take the lead 1 second in order to say that now we are using Safari wire. You have to be aware, I guess, that the Safari wire is a long TAVI wire and is not dedicated indeed for the transcarotid route. So this is why we have to use a specific setting with the tables. I think now you have a broad picture of how we are set, and you can see that the Safari wire is bending along 2 tables with 3 people. Indeed, it's human resource demanding, but it is the safest way to use a Safari wire, which is a long wire. We ask actually the company to whether we can have a short Safari wire, and I think that they are working on it. This is something that maybe can be discussed because it makes our lives a little bit more complicated. This is indeed the Edwards setting, and for the Medtronic, it's going to be exactly the same because it's the delivery sheet is very long, or other valves are having to face the same issue.
Any comments at this stage? So what we have now, we have the pigtail in place. We have the Safari wire nicely curved at the apex. We have a temporary pacemaker in place. As you know, there is a permanent pacemaker, but for safety reasons, we have a temporary pace in place for the valve delivery.
Now it's a very important phase of the operation. It's the dilation of the carotid artery.
Okay, so do you want to comment on that, Matthias?
Yes, I think it's to avoid too much of a carotid injury, we are very carefully to dilate very progressively the vessel. So we use 3 dilatators, 12, 14 and 16 French, before we put in the introduction system.
Okay. How far are we with the valve? Is the valve ready, Pascal?
Oh, he doesn't have a microphone, so
take your time.
Pretty almost.
Okay. Any questions? Because we are, it's like a monologue from Lausanne. We are very open for any comments we have a little bit time here because you're going to dilate. We are going to put in the sheet. So I think we need about 5 more minutes before we're going to get the valve into place.
Hi, Eric. This is Florin from Lucerne. How many % of your cases, of your TAVI cases, are you doing non-femoral?
Oh, it's a minority.
15.
15%, Olivier. It's good.
15 is a lot because we have much less.
15%.
Yeah.
Yeah, but I think that maybe in the French part of Switzerland, people smoke much more than in the German part. They're a bit more, you know, Latin people. Huh?
And more cheese.
We enjoy life. We enjoy life. No, that's not a very scientific remark and an answer. But yeah, I also, we had to comment from Eberhard, you know, if the transcervical approach would not be that straightforward and easy, probably we would do differently. But it's basic, as you can see, such a quick and straightforward procedure that in case of doubt, we proceed like this. But on the other hand, it doesn't mean that we sometimes will perform angioplasty of the iliac or the femoral access routes. Yes?
Yes. Now we have introduced the introductory system. You see, we don't push it too far. We stop at the level of 4 centimeters because we're very close to the aortic valve. And then we retrieve the introductor, always checking that we don't take out the guide wire, obviously.
Okay, in the meantime, the valve is ready. Vladimir, you want to go and get the valve? Or,
yeah, sure. Let's check also the valve position with the angio. We still have to perform the angio.
Where would you plan to align the valve?
Yeah, the alignment of the valve, as Olivier already showed you, is a little bit more cumbersome with this technique, and you will see it straight away now. We only have one level of articulation, while with the classical transfemoral we have much more level of, and you will see the valve is a little bit not really horizontal, but a little bit inclined. So I think you will see that. Did you already do the angio before?
Let's check the angio before.
You did the angio?
Yeah. Can you show?
The angio before you get in. So can you get the? Okay, we'll do now a direct angio to show you the valve plane. Okay, go ahead.
Looks perfect.
What about the?
Yeah,
it's almost perfect. Yeah.
And so here you have the delivery device and the loading system.
You want to check the rapid pacing again before getting across the valve, or is it okay, Olivier?
Yeah, we can check the maybe.
Check once more the rapid pacing before getting the valve across the main
So can we just flush a little bit the the hemodynamics in order to have a proper curve?
The assist device is, of course, as you know, that we have a damp pressure tracing.
Okay, I think we can do it with the syringe.
Vladimir, yeah. It's much better. How is the hemodynamics, Lorenzo?
We are correct. We are stable with the hemodynamics.
Okay. So we test the.
I'll say it for you.
Sorry, we test the pacemaker. Pacemaker on. Pacemaker off. Okay. So I think the system is working very well, and we'll proceed
now
to the amplifier.
We push the valve through the sheath.
Do you want to center the images a little bit?
Yeah, sure.
Move the table just a little bit.
So once the valve gets outside of the sheath, you have to de-air the system. Maybe you can see this on the screen. You have to see the blood coming out from the loading device. And then we push the valve into position. Okay, and we start to discuss about the adequate height of the valve.
So this alignment is quite nice. Mostly it's worse. But
okay, we'll test. Vladimir?
Yeah, I'm ready.
It's a big valve, huh, guys.
It's a 29 valve. I don't know if the panel wants to comment the position rapidly.
We have some time. Hemodynamics are fine, Lorenzo.
Maybe a little bit more aortic, I agree.
Yeah.
Maybe a bit too ventricular.
Little bit higher, I fully agree, yeah. A little bit higher.
Tu scopes là?
No.
That's already quite high.
Okay, we can retest.
Not higher than that.
I think the position is quite nice. It's quite high to my point of view. I don't know if the panel is okay with the position and plant. Oh,
Can you have
getting down.
The first and second.
Getting down. Yeah, I agree. We'll try to position a little bit higher here.
But I think everybody now tries to implant higher if possible in order to deal with the...
Just a small test, Vladimir.
I should be fine.
Yep.
Looks good,
A
yeah.
little bit higher. Yeah, here. Yeah, that's
I would
perfect.
agree.
So, pacing on.
Pigtail out.
Yeah,
Pigtail out.
exactly.
And Olivier will inflate the valve soon. Okay.
So we have a nice decrease of the pressure, and I will start slowly but continuously inflating the 29 valve. I'm deflating, and we will retrieve the delivery system and pacing off.
It's interesting you did not inject again while inflating, because I would have injected again to check for the final position and be able to correct if possible or if necessary.
Yeah, but the peak was quite nicely stable, and I think we were able to judge.
29mm valve also, so these valves are more.
But I agree, Florim, that this is also a possibility.
Take your time, guys, because we are running a little bit on. Not ahead of schedule, so we have time.
La pression,
yeah,
là?
we have time with 12 minutes. Yeah.
Yep.
Yeah. Be careful of the wall.
So we can have a look to the position of the valve. Vladimir will position the pig, and will. We need a second.
No, we can just do a pullback. It's up to you.
Okay.
Let's already look at the. So if you pull on the more rigid part of the safari wire, you will not have an effect of regurg because of the wire.
Vlad?
So let's make a picture there.
Yeah. Okay, Vlad.
When you're ready. You want? I'm ready.
Okay.
That's probably the wire in use.
But I think the valve is nicely implanted. The position is quite nice. It could be a little bit higher if you want to avoid any pacemaker issue. But if you are able to see the ECG, the curious is.
The pacemaker anyway. So
yeah.
Yep.
But in general,
we try to really put the valve. We're going to Lorenzo.
It's 140.
Is fine. Yeah.
The diastolic pressure.
Mean arterial pressure. You want mean
the diastolic pressure
80 is the mean arterial pressure. 80.
Copy.
You want to do a quick gradient or?
Yeah. So we keep.
I don't know if it happens in your practice. We don't always do it, but maybe we can just showcase the gradient if the right stays in. Can you connect Vladimir?
Yeah, we're just coming over there.
The assist.
There was still some aortic regurgitation, and I hope now after the removal of the wire we don't see that anymore.
We hope also.
Okay, we can bet on that, yeah, but I think it's a wire.
Can we have the second line?
I think it's a wire. It's the safari wire. The way it looked, the way the PVL looked like the wire induced, because if it's really a PVL, it tends to look a bit differently. But I can be wrong, of course.
Maybe we can magnify the hemodynamic screen.
Yeah. Can we magnify? Can we? Let's do that.
Or just that'll be great. Yes.
It's coming. It's coming. Yeah, we're just connecting.
Yeah, we can see it very well.
Il faudra qu'on ait une pression.
Ouais.
I'm going to shift to French for 1 second. Est-ce qu'on peut nous mettre la pression hydraulique et la pression assise?
Ouais, je suis prêt pour faire le zéro.
Pour avoir un gradient.
Alors, on peut faire le zéro.
Élevé. Oh, now we shift back to English.
0 on the 2 lines.
You'll get that in 2 seconds.
That's French for a good job, guys.
Diastolic pressure is still a bit low. Okay. Very unusual for an Edwards valve to have this. I think you have still some AR.
We will check it. Can we take out the big pressure and we'll keep...
Can you look at the scale here? Because
wait, just like we do not check.
The scale was not correct. Huh? Let's look at.
Okay, so.
Yeah, the 0 is not correct. Sorry for that.
Okay.
Maybe you could
0 for the 2 lines, please.
0.
Yep.
You can zoom into the hemodynamics again. Yes, thank you.
Yeah, it's coming. It's coming.
Okay, that's the 0 for the 2. That's the. Okay, that's the aortic one.
Yeah, that's
okay.
Much better.
Okay.
Because
that looks.
I didn't believe in the previous tracing.
Yeah.
That was not possible. Huh?
So as you can appreciate, there is no gradient anymore.
Excellent.
And the Florim is aware that maybe we can still have some aortic regurgitation and look it out.
Yeah, 50, you're right. It's correct, 50. We'll check that now. Okay.
Okay.
But I would like to see another aortogram.
Yeah, sure. But I think we have to take out the our guiding in order to have a valve. So pulling back.
Okay.
Okay, I think the gradient is perfect.
I may be wrong, Florin, but to my opinion, there will be almost no leak.
Okay, Vladimir, are you ready?
Yep.
Let's go.
Yeah.
Edwards.
There is some very minor aortic regurgitation.
Angiographically looks very good.
Florim, are you happy with the result?
I'm used not to see any AR after an Edwards, so that's I'm insisting. But if maybe Dr. Gruber can comment, he's probably the most experienced.
No, I think you're right actually, and you can see it's a little bit unusual that you have a gradient. I mean that you have a diastolic pressure of 50 in a Sapien. Usually you would like to have it, but considering, and I don't know how much influence the anesthesiologist has on the volume of the patient, so I'm not sure whether I can judge this, but ordinarily I would like to see a little bit more diastolic, and I do agree with you, there is some aortic regurgitation.
What was, can I just interrupt and comment on that? Lorenzo, what was the diastolic pressure at the beginning of the procedure?
It's there, it was 52.
Was Dila?
Oh?
No. No, I agree, but on the other hand, you know, we see on occasion, we see minor aortic regurg after PVLs, after TAVI, and this is a 29 millimeter valve, nicely implanted. We have the adequate volume. I don't think we can do much more. We also have to leave the valve, do it work. I think probably that the if we repeat the injection in 5 minutes, it may be probably better. And I agree that we see less regurg, but on the other hand, if you don't see any regurg after Edwards, that means that you haven't done enough Edwards valves. I would say that because we see it on occasion. Olivier, you agree?
Yeah,
always
on top, I would say that we have Sapien 3, not an Ultra. I don't know whether you are talking the results of the Ultra. Here we have used Sapien 329. Okay. And to my point of view, there is really a tiny regurgitation. And I have to confess that the diastolic pressure is 60 now. So it's getting higher and higher. And I think maybe this is due to the inflation of the skirts and the sealing of this minor aortic regurgitation.
We need to go on. What we're going to do, Matthias is going to demonstrate the closing of the access because we have 10 minutes left, 5 to 10 minutes left. And then we make the final conclusion, and we will do at the very end. At the very end, we will do an injection again, and probably there will be less regurg. Okay, so Matthias, the word is to you.
So here again, the decannulation, we're going to use rapid pacing to avoid any carotid injury. Pacing on. You have already the clamp in place. I hope that you see it. Once there's no pressure anymore, je vois pas le. Voilà, c'est bon. Okay, we decannulate. And there you have the opening. We don't use the purse string suture to close the vessel. We reconstruct it using single interrupted sutures. Face off way. History.
So Henry, how much time do you need for your presentation? 2 minutes, okay.
Les ciseaux, petit.
Eric, can I have a question?
Yes.
6-0.
Yes. Go ahead. Yes, we hear you.
Yeah, Eric. Since, you know,
yes,
I heard you're using 3 dilators for the Sapien valve on the carotid. You know, any thoughts on using or taking advantage of the lower profile of the evolute without using dilatations?
Je vois pas le fil.
We haven't done any Medtronic valves from the cervical transcervical approach, but we made that discuss that within the team, but we haven't done it. We haven't done it, to be honest.
Okay.
We have 3 minutes, 4 minutes left. We're going to very briefly show you our data. Can we focus on Henry?
Yes. So can you hear me?
And can you show the slides? Yeah.
Sure.
Okay, go ahead.
Okay, so good afternoon, everyone. My name is Henry Liu from the Service of Cardiology at Lausanne University Hospital. And next, please. And today I will present to you the results of a study that was recently published in International Journal of Cardiology. Next, please. So our objective was to compare transcervical access versus transfemoral access for TAVI. We used retrospective data, uniquely from Lausanne University Hospital. So that was a monocentric study. The endpoints are listed here. We had 30-day mortality, procedural complications according to the VAC2 criteria, and the endpoints also included the hospital length of stay. Next, please. So maybe it's okay. Thank you. So from January 2016 to May 2020, we included 255 patients in the TF group. TF stands for transfemoral, and 51 patients in the transcervical group, so TC group. And as you can see at baseline, patients in the TC group had higher surgical risk, illustrated by significantly higher STS scores and a trend towards higher Euroscore 2. Next slide, please. And patients in the TC group also had a higher prevalence of peripheral artery disease, a history of cardiac surgery, and a history of stroke or TIA. The other clinical or echocardiographic characteristics were otherwise similar between the two groups. Next slide, please. And concerning the perioperative outcomes, as you can see here, there was no significant difference between TF and TC. Next, please. Next slide, please. And that was also the case for the 30-day outcomes, especially for the all-cause 30-day mortality, hospital length of stay, neurovascular complications at 30-day, and major vascular complications. So as a conclusion, I would say that in our single center experience, despite a higher risk, surgical risk, and more comorbidities in the transcervical group, the transcervical access and the transfemoral access had similar results. Thank you very much.
Thank you very much, Henri. Let's now maybe, because we have 2 minutes left, I think, can we do a last injection, Vladimir? You're almost ready, closing the skin,
no,
Matthias?
not the skin, but we're finished the carotid. We're just de-airing the carotid.
Okay, how much time we have left transmission?
Eric, we have about 20 seconds left. Excellent job.
Okay, we need to do the angiogram. Let's do the angiogram again. Matthias, just 1 second.
Enlève ton truc. On doit
Copy down.
descendre.
Give us 5 seconds to do the injection, please.
Sure.
Okay, Vladimir, go ahead. Okay. Go ahead. You see? It's
excellent results.
I think there's nothing else to be added here. You see really the effect of the skirt. So if you have 10 minutes left, I would like to thank the group of SingLIVE, all my friends, old friends from over all these years for the opportunity to broadcast this case. I think we managed to do it on time. The surgeons are almost closing the skin now. So thank you to all the panelists for your valuable input. And by the meantime, the diastolic pressure has gone up to a normal level again. So I think we will leave it from there. And looking forward to the next Singapore Live meeting in 2022, hopefully again in Singapore. Thank you very much. Have a good day. Bye-bye.
Thank you, Eric. Excellent work. Thank you, everybody, for attending the session.
Thank you.
Sorry.